webinar process before. I'm used to watching for nonverbals from the audience, so I have planted a couple of question slides in my presentation so that it'll remind me to stop and give everyone a chance to ask questions. And as Jen said, if you would type those in when I ask for questions, she'll relay them to me, and I'll do my best to respond. I've got about 40 slides, give or take, so hopefully we'll have time at the end also to ask questions if folks would like to ask things that I will not have covered. So that being said, I think it's okay for us to proceed. So MST, Multisystemic Therapy, has been around since the probably late 80s in terms of an idea or a concept in Scott Hengler's, our model developer's mind. Lots of research we'll talk about in a few minutes. The MST Services portion, the kind of purveyor organization whose job it is to help with the dissemination of the model, has been around since May of 1996. So we are just about to hit our 17th birthday, and are looking forward to kind of hitting that mark. Many kind of startup companies don't make it that far, so we're very happy to have survived this process. And we'll talk about some of the reasons why I think that is as we move forward. I think one of the kind of pillars of the process that has helped us become effective and stay effective is our research and dissemination kind of model. The Family Services Research Center at the Medical University of South Carolina is where Scott Hengler has done the lion's share of the research work about supporting MST. MST Services, the breakout organization whose job it is to just work with communities to replicate the clinical model with fidelity in communities that ask for the services, so that we can do our best to ensure that the communities are doing the things we need to do to get outcomes. Into the kind of big picture dissemination world, one of the things I think that's been lacking for a number of years, and I'm a psychologist that goes way back, is a way to kind of measure whether or not what's being rolled out is getting done with fidelity, and then looking at the long-term outcomes of that process and making adjustments as needed. The next bullet point is the MST Institute, and that's a kind of a not-for-profit organization whose job it is to house all the data. So those of you out there who have MST teams operating, when they say they're going to go into the website and pull data on the number of families served and the average length of stay, we'll talk about those things in a few minutes, that's the place where they go to get that information. And then lastly, in terms of the dissemination process, there's a group of folks out there that are providers, like I think some of the folks on the call are, and also network partner organizations. Network partners came into being because we realized, we at MST Services realized that a lot of what happens in the building of capacity in different states is done locally through local relationships. And having someone come in from South Carolina, there's value in having the voice of the model come, but at the end of the day, if we're going to build capacity, it's going to be the local organizations that help us with that. So we've identified about 22 different network partners around the world whose job it is to help us disseminate the model with fidelity. In terms of what we are, I know there's a wide group of folks out there. Some of you may be very aware of MST. Some of you may not. So I'm just going to cover a couple of things here related to how we work. One of the things that we try and help communities do is find a way to take youth that they typically would send to a placement and keep them in the community by providing community-based services that are intense, that are tailored to meet the needs of the family. And so antisocial, delinquent behavior, acting out, stealing, sometimes physical aggression towards the parents or staff members at school are all kind of hallmark behaviors for us to work with at MST. Big focus on getting their caregivers to help figure out how to solve those problems with their youth. Rather than kind of saying, oh, they don't care, we're more along the lines of understanding how it is that the family system came to be in this situation and once you help the family understand how they can move the system and empower themselves to be problem solvers, they often will, take charge and run a system. Not to say they're always perfect families at the end of treatment, and not to say that things don't happen to them in the future that sometimes get in the way of progress being maintained. But in the big picture, many families can move forward and keep their youth out of trouble. We consider our client to be the entire ecology. I'll talk more about that in a second. It's the name of the youth is on the file when we open it, but really it is the family, the peers, the school, the neighborhood. In addition to the youth, all of those need to make some adjustments around the youth to help him or her be successful. And then a very highly structured clinical supervision and quality assurance process. Very, very structured. We used to talk about MST supervision and consultation as it's a work group put together that meets once a week to help families get outcomes. That's why we meet. That's our sole focus of why we're there. The goal is to make sure that we have the most clinically adherent to the model plan we can put on the table for every family every week. And if it's not MST, we need to change it to be MST. Our standard referral criteria, Peter said, one of the things he talked about it when he did when he kind of did the byline for this was, who do we work with? And so these are the criteria. This is, again, based on the research data. People at risk for placement is really the hallmark. On a continuum of, least expensive service to most expensive services. If you're using MST for the population of kids that typically would go to placement, MST will be a much more cost-effective service. If you're using MST to treat kids who could benefit from outpatient service, then we're going to be more expensive than those kind of services. And so we really want to focus on those kids who are, I used to talk about them as the judge has given them, one last shot. They got 1 foot in jail and 1 foot on a banana peel. And the goal here is to make sure those are the kids that we're seeing, working with those ecologies. That's where we think we get the biggest kind of bang for the buck in terms of the model. The rest of those there, the exclusionary criteria, the things that we don't work with, we need an ecology to work around the youth. So independent living youth are not really where we would focus our time. Sex offending in the absence of other antisocial behavior. Youth that are actively homicidal, suicidal, or psychotic at the time of referral, we tend to say, let's get them stable on some medication, let's find out what we need to do to get them, and then maybe there's an appropriate referral in the future for them. And then that last group there's a kind of a gray area here in this process where, and you guys who are out in the field know this on a regular basis, you can have a youth who's got a history of kind of having psychiatric challenges in his life, and the family does their best to manage that. And the last time he had one of the manic episodes, whatever it is you'd like to put in that box, he stole a car. And so now he's been in front of the judge, and he's got a charge. So he's a juvenile justice kid with a history of psychiatric problems. And that youth is different than a youth who's got a long history of juvenile justice problems, stealing cars, hitting kids at school, been charged multiple times, and the last time he was in front of the judge ordered a psych eval, and now he's got a diagnosis. And so we try and look at that continuum of kids from the one end to the other and figure out which kids are most appropriate for MST. And for us, the most appropriate kids, and again, it gets gray in the middle, is the group that I talked about last, the kids who've got a long history of juvenile justice issues. And now they've got a psychiatric diagnosis, and we're looking for services. That's probably the best MST kid I can get. Sometimes you have to make judgments about the kids in the gray areas. Where we are right now, 34 different states, 13 countries. See them listed here. I think one of the things, I think I saw some folks from North Carolina out there. We now have, North Carolina is one of the states that have started MST and used it as a kind of a mechanism for changing service delivery in the state. And I think as of last week, there are 36 MST teams operating in the state. So one of our large state infrastructures, almost statewide. We have a few counties that currently report not being able to access service, but in general, of the 100 counties, I think 86 or 87 counties can have access to an MST therapist if they need one. So we're working to fix those last 13 or 14 counties. So just a bit about the theoretical research underpinnings and then the theory of change. Many of you who are familiar with MST have seen this. The role the family plays either as protective factors or risk factors, and the school plays in protective or risk factor ways to have access or lack access to delinquent peers, so that and delinquent peers predicts, our youth, our referred youth, behaving in delinquent ways. So one of the things that MST does is try and take a look at those different boxes: family, school, community context, and figure out how we can change those to help the youth be more successful. At the family level, very common for MST youth to have inconsistent monitoring. When I was growing up in Indiana, it used to be at 11 o'clock at night, there was a public service announcement that came on television that said, "It's 11 o'clock, do you know where your kids are?" And this is the prime kind of way to think about it from an MST standpoint. These are parents who many times, for a variety of reasons, sometimes they're working, lots of drivers to the fit of why they would be unable to be there monitoring. But if you ask them where their kid is in a given moment, they would probably say, "I'm not really sure. I know he told me he was going here, but he could have gotten in a car and gone someplace else, and we really don't know where he is right now." And because they don't know where their youth is, and they're inconsistent in how they provide discipline around him being where he should or should not be, many times there's lack of strong positive affective relationships between the youth and the caregivers. And it's very common when you're working with these families, when you kind of talk about the negative affect they developed, what you learn about these families very quickly is that they fight about the same 4 or 5 things all the time, and they fight about it in exactly the same way. And so once you start to understand the sequence of how they get themselves in those negative interactions and get people to start to change what they do in those situations, what mom can say differently, what stepdad can do differently, then you can start to change the negative affect and replace it with some positive affect between the youth and the caregivers. And then sometimes parents themselves have substance use or mental health issues that have to be dealt with in conjunction with, so they can be a better caregiver for their youth. At the level of peers, association with other kids who use drugs and engage in delinquent behavior. I talked about that before. Sometimes the youth that MST works with are either rejected, they're just a social isolate at the school environment or in their peer environment, or sometimes they only have an acceptance by that one group of kind of negative peers. And I say negative in the context of I don't like it when you label people as groups, but in terms of this presentation, it's helpful to kind of see there's this kind of kid out there that our kid hangs with that helps him or her get into trouble. At the school, academic problems, they're not successful there. It's hard to stay in a place where you're not successful. They often have behavior problems. They don't have a very positive attitude about being there. And then sometimes the school will have a program the youth needs to be in, and the ability to flex that program or allow a study hall or allow something to happen where they can go to school half day and go to some kind of vocational training program half day is not available to the youth until he or her can demonstrate some academic success. And so sometimes that lack of flexibility keeps our youth in a place where the school and the parents kind of stay at odds with each other. And then at the community level, a lot of transient neighborhoods, they don't know who their neighbors are. They can't rely on the neighbors for support or help. A lot of stress in the neighborhood, weapons, drugs, again, congregations of negative peers that is easily accessible to the youth when they leave the house are all common places where at the community level, the therapist often will go in and try and help the family make some changes about how the youth accesses those community drivers. Can we find a way to keep them off those street corners, away from the places where those youth are? And then the youth themselves sometimes have contributing factors. They're often impulsive, whether we call them ADHD or conduct disordered or how you float that out here. To me, the diagnosis is less important than many times our youth are not good decision makers. They tend to look at the environment and see things in ways that they've learned across time are more volatile than most of us. So, they look at a situation and you ask them to interpret what's going on, and they'll say, well, they're getting ready to have a fight. And you look at it and you go, I don't see that. Tell me what you see. They think about the world. They see the world differently, and our job is to help them through some cognitive restructuring processes and working with the family to help them to restructure the use cognitions, to help them get more tools in their tool belt for managing those kinds of situations. The theory of change, I think that this may be new to some of you. Some of you might have seen it before. The whole process is for that MST therapist on the left part of the slide to get enough improved family functioning so the family can manage peer interactions, school interactions, and community interactions in such a way that the youth is unable to participate in negative interactions in the community, or, and again, because these youth and families aren't perfect, that the youth may get out and do something negative in the community, but the parents are aware of it and they hold youth accountable for it. And that's really the primary way that MST wants the youth to get better. We're not going to say that a kid who's got a history of stealing cars and shoplifting at Walmart will never do that again. What we want to be able to say is that the youth is now in an ecology where when it happens, parents know about it, the parents confront the youth about it, they hold the youth accountable in ways like many of our families probably did when we were growing up. You go back to the store, you return it, you apologize, you pay for what you took, whatever it is that makes that happen for folks. The assumptions, I think I've got a question slide here coming up in a minute. We want to make here is that families can impact each other's behaviors, the different family members. It's not that these behaviors happen in isolation and you can't have an impact on them. The families are important parts of this. Every family wants their kid to grow up to be some kind of productive. People didn't have these kids to grow up and say, I want you to grow up to be a drug dealer. They wanted them, they had dreams for these youth at some point, and we wanted them to figure out what they are and help them reconnect to that. We believe families can live successfully without formal services in their lives, and that change can happen quickly. It doesn't have to take 1 or 2 or 3 years to get this to happen. We believe strongly that treatment providers should be accountable for outcomes, and that research and science can help us figure out how to best do these interactions in ways that help families make these kinds of changes. Last slide, I think, before the first set of questions is implementation. Again, the goal is to help communities get the same outcomes they got in the research trials. And so to the extent that we can replicate the kind of supervision, the type of clinical training, the type of ongoing quality assurance that happened in the research, we believe we can help communities get those outcomes. And so we provide ongoing training and support, weekly consultation, supervision. Every MST team gets a quarterly booster where the expert assigned to that team comes on site and works with clinically relevant training topics for that team and those therapists. We provide organizational support for MST programs, implementation monitoring, and then kind of a feedback loop. So every MST team gets a kind of a 6-month, we call them a program implementation review. It's kind of a 6-month look at how'd you do the last 6 months. What was your length of treatment like? What were your outcomes like? What was your adherence data collection like? And then based on that information, what do we do the next 6 months to improve it? It's very seldom we get a perfect implementation, so there's always seems to be something to work on. But the goal of this is to help the teams and the communities, A, know what is going well, B, what's not going well, and then have a plan to address it so that it can continue to move towards a more positive implementation. So let me stop there and ask Jennifer if there's any questions on the list that I might be able to respond to before moving on to the next group of slides.
Not at this time. Not yet.
Wow. Either everybody's already familiar with what I'm talking about and I'm going way too slow, or I've done a really great job of explaining it, and I don't know that the last one is possible. So we'll just keep trucking on here and see where we end up.
Well, actually, it looks like we have a question.
Okay.
I'm just waiting for that to come through. Oh, here we go. How does a company or provider gain an MST team?
Excellent question. One of the things that we learned early on in the implementation process is that there needs to be strong community support to start an MST team. It's difficult for a provider just to call up and say, or anyone to call up and say, hey, I want to start a team. So we've done some work in developing some, we call them program development tools, where if someone does call and say, I think MST would be a good addition to my community, we have several kind of steps we ask folks to go through in terms of identifying the availability of the right kind of youth. I mean, I know as I talk about this, everybody in their head says things like, well, we've got lots of those kinds of kids in our community. Everybody does. But it almost never fails that you put an MST team on the ground, and the first year they struggle with referrals. Because everybody says the kids are out there, but then it's a matter of, okay, who needs to know about it? Who has the kids? Are they available when I need them? Because the caseloads get full, and you can't keep taking all the referrals you want. And MST kids tend not to do well on wait lists. I mean, these are kids that are impulsive. They act out. You put them on a wait list and say, I can see you in 3 months. There's a good chance within 30 days you're going to have a charge. And so you need to find a way to manage the referral flow so that you have a consistent set of kids coming in as you get openings in your caseloads. So we look at the number of kids available. We look at the level of community support. We actually, at the end of the program development process, will have a site readiness review meeting where we essentially send one of our program developers out to have a community meeting and look at, invite probation officers and school staff and anybody that we think will be an important part of the ecology around this team, and make sure they all understand, if the team is starting and this is what we need to have happen, develop the referral process. It typically will take somewhere between 90 to 180 days from the time we get the first call until the time a team's actually on the ground. We do help with hiring. We work with organizational leaders that will house the team to make sure that they're on board with the kind of differences that MST brings to the kind of clinical organization process. We've come to, we have this way of thinking about it is that MST kind of will be, I think that the phrase that they use is in your grill, about a lot of practices that need to be different for MST to be able to be effective. So 24/7 access by families to the therapists. They have to have cell phones. They have to have access to a car that they can transport families. And so if those kinds of things don't fit well with the organization, we have to do a kind of stop and say, well, wait a minute, we have to, MST needs this to happen. If you can't do these things, then maybe we can't work together. So there's a long list of processes we go through to make sure the organization and the community are ready to house the MST team.
Thank you. We have another question. What are the qualifications for a network provider?
Good question. Network provider organizations, network partner organizations, I'm trying to think how to best to frame this. The ones that are network partners now typically came up through the clinical process. So they started because they had some MST teams, and they grew their MST capacity in ways that made it that made it easier for them to say, I can now bring this capacity internally, in terms of my organization. So I think the rules we have written about that right now are that you have to have a minimum of 5 MST teams operating with a plan to get to 8 MST teams within the next 12 to 18 months. And if you have that kind of capacity, then it can make sense for you to have your own internal expert that will be coached by someone at MST Services who will do all the training with your teams. You can either choose to then, as a network partner organization, keep managing teams that are part of your, so in other words, both the provider and you're also the network partner organization. We have some organizations like that. But then you also could reach out to other organizations and communities around you and offer to provide expert services to them as well. And we have organizations that do that. So it's a very tightly managed, if I could say it that way, because the clinical processes, rely on that. But also kind of flexible in ways that, if you can have a blend of, 5, ABC providers got 5 MST teams in Ness County. There's XYZ provider, and they've got 3, and you guys can find a way to work together, and that can be 8 teams. One of you can provide the expertise process. That's something that we can have a conversation about. Very common in this process, kind of walk through the budgeting. People tend to think about this as something that, this is something we can make a lot of money at, and it tends to not be something you can make a lot of money at. It'll be okay, but it's not going to be a cash cow for you. So.
We have another question, Joe. How consistently do you find MST being sustained by Medicaid funds?
Oh boy, that seems to be the $6 million question right now. I have 2 different answers to that. If you go to our website, and there's actually a place where you can get some information about Medicaid funding, we have different standards by state. You can take a look at some of the things people have done. But one of the things we talk about there is we don't believe that an MST team can function on Medicaid funding alone. And there's a couple reasons for that. One is Medicaid, in its regulations, very clearly says that there are some things you shouldn't use Medicaid dollars to pay for, right? And so supervision, travel, things like that are important to the MST model that from their perspective you're not supposed to use those dollars for. So having some kind of blended or other funding stream, in North Carolina it might be called IPRS dollars, in Pennsylvania there's other kinds of county dollars available for those kinds of processes, or just had a phone call with someone in Pennsylvania yesterday where one of the counties are looking to put some monies together so that when a youth is referred who may not be Medicaid eligible yet, they can start services, and then Medicaid will start kicking in when the eligibility hits, so there's no delay in service delivery. So if there's opportunities like that to build funding in, that would be ideal. So the big answer is we don't think it's a good idea to try and make that your only funding source. Folks are trying it. They're doing it. We've had, in fact, the states where we've had kind of the largest growth recently, North Carolina, Louisiana, New Mexico, are all states where Medicaid plays a big part of the funding of those teams. But as you know, as budgets tighten, then those 15-minute rates or those case rates are subject to cuts, it then starts to kind of whittle away at the sustainability of the team. Having that second funding or that blended or braided funding stream allows you to ameliorate some of that risk.
Thank you, Joe. I think we can continue on at this time.
Okay. I'll move down through a few more slides, and I have one more question mark coming. So just a bit of more of the research process and some of the transportability findings. The slide here was built in 2010, and so there are now actually 32 published outcome studies about transportability and benchmarking of MST at different places around the world. You can see the different populations here, and I will talk more about adaptations toward the end. Juvenile offenders, substance using, substance dependent juvenile offenders, juvenile sex offenders, MST psychiatric, maltreating families, obesity, diabetes. So a fair number of places where the standard MST, is the MST for juvenile offenders, that's kind of our bread and butter population. but we're also taking a hard look at whether we can use the kind of the foundational MST processes, accessing the family, using our treatment principles in ways that, with some modifications, adaptation, could be used with other populations. In general, we get better outcomes than control groups, whatever, again, across multiple studies, control groups vary. Sometimes it's another treatment, sometimes it's usual services. In general, families, when we do MST well, report that they like what happened to their family. Long-term rearrest rates are down. Long-term out-of-home placement rates are down. Again, in the context of the cost structure, I want to go back and revisit that point. If you use MST with the youth that are costing your community the most dollars, the kids that are on their way to placement, either juvenile placement or some kind of a treatment center, and you can keep them out, then that, whatever it is, $600 a day, $300 a day, whatever they paid for that treatment episode at the placement, MST can reduce those placements, the need for them, and do it in a way that saves the community dollars. And typically, an MST episode, depending on the biggest part of the MST cost, is related to the salary of the therapist and the team. And so if you're, $9,000 to $10,000 to $12,000 for a treatment episode of MST, you can spend that in. I used to work with MST teams in Hawaii, and back in Hawaii, the treatment dollars, the treatment cost per placement was $600 a day. So, in 20 days, you've spent enough money to do a whole 4 or 5 months of MST. And that's where we really feel like we get the biggest bang for the buck. But in order to get these outcomes, you have to have adherence to the model. You have to get the clinical work being done with fidelity. The long and ultra-long outcomes for the kids in trials and treatment. So again, you can look at these numbers. Kids were treated in 83, 84, and now they're 22 years post-treatment. Again, not perfect families, not perfect kids, not perfect now adults, but they function better than their non-MST treated peers, and they function better in ways that keep the cost to communities down. So it's not like they never got arrested, but their arrest rates were way down compared to usual services. Not they never spent any day in confinement, but they spent way less days in confinement. Again, this is average across the service, so there were some people who never went to jail ever and some people who went longer, and in general, 33% fewer is a big savings. Again, think about the cost per day for someone to be incarcerated. That saves substantial dollars to communities. And again, less family disruption. Don't seem to have much impact on the financial problems. I'm not sure what the fit of that is. I do want to spend just a minute talking about the transportability study. As I referenced earlier, there's a long history in kind of psychology, social work kinds of areas of developing, quote, something that works, unquote, and then trying to roll it out into communities and finding out that in the rollout, in the transport of this service into their usual everyday world, it didn't work. And you scratch your head and go, well, what happened? And the way that people on the other side of this world see that is, I've gone to many different communities where you walk into the room and talk about, bringing something out that's evidence-based, and probation, school counselors, and they all roll their eyes and say, yeah, you're the 9th one we've heard about in the last 12 years. So to be fair, I think there is some reason for folks to be a bit skeptical. So we wanted to take a look at, is our transport process, this method we're using to move MST out of the research world into the real world, working? So we did this transportability study across a 5-year window of time, 45 different programs, almost 2,000 kids and their families, and got significant reductions in post-treatment behavior problems, in criminal activity compared to usual services. So it gave us some research evidence that suggests that this transportation model of Everybody has to go to a 5-day training. Everybody gets boosters. Everybody gets an MST-trained supervisor, an MST-trained expert that reviews all the cases every week. They get a booster every 3 months. That all of that work around the team helps communities get the same outcomes that we got in the research trials. Adherence measures. We ask the families to tell us how well we're doing the model. We ask the supervisors to report on we ask the therapists to report on their supervisors, and we ask the team to report on their expert, their consultant. And to the extent that those adherence measures are high, families get better outcomes. When they're low, families don't. And so again, more research evidence to suggest that we can have a real-time measure of treatment fidelity, that we know if you score above this measure, this number on this index, that therapists who do that job well, that threshold is 0.61 for the therapist adherence measure, and they get above 6.1 or higher, they get better outcomes for families than therapists who don't. So our treatment protocols then focus on how do we get this therapist to be more adherent to the model. Oh, that's not good. I don't know why that happened. There we go. Treatment adherence predicts the things that we want the communities to be able to experience. Less criminal activity, less arrest, less incarcerations. That's what we're after. When we are asked to come in by providers to communities, one of the things they look for is, we've got this block of kids. And back when I was a young psychologist, I used to work at an inpatient unit where, you'd have this group of conduct disorder kids in trouble with juvenile justice, and a community would spend 80 to 90% of its dollars on that 4 to 5% of the kids who were causing all the ruckus. So if we can fix that dynamic a bit, we can get those rates down, then hopefully the communities can have dollars to spend on the kids who are depressed and the kids who are not acting out and some of the other things that need to be addressed with youth and families. And then finally here, just again a kind of a visual view of what I just talked about. Things the expert, let's label here as the consultant, the supervisor, the therapist do, we have research evidence to suggest that those behaviors matter when it comes to getting outcomes. And as far as I know, I think MST still has the only published study of if something happens in supervision, does it matter to outcomes? And I, again, been a psychologist for a long time. I remember going to supervision in grad school and sitting in the room with all my colleagues and talking about cases. And so from that long history, probably back to Freud, who knows how far back that goes, for no one ever to kind of ask the question, does what someone sets in supervision matter to outcomes? It's an interesting process to me. So, but we have some research that suggests that what that supervisor does is important. Supervision is not about going in, patting each other on the back and saying, oh, our jobs are tough and, we need to have, it is tough. These kids are tough kids to work with. These families are not easy families to get engagement with and to make change. But the goal of supervision is to help that happen. So it's a different way to think about the process. So let me stop there and ask Jennifer if there are more questions that have come in. Based on
just one.
Or from previous. Okay.
So what is the grade where you say this team is not making the cut?
Another great question. It's one of the places where I think we're having some what I would call learning edges in related to dissemination and implementation. When you say you, I assume you mean we MST Services, we try, let me answer the question this way. Given we have an ongoing kind of feedback loop for getting change to happen at the team level, we have an expert attached to that team. They monitor the outcomes of the team, and I'll show you how they do that in a couple minutes. We would allow that first implementation window to go by, and there'll be some things to work on, and then we'll work on them, and they don't change, and then they don't change. To us, it's less about how long or what markers are, and more about are they making progress in ways that we can see a light at the end of the tunnel. So that's kind of one way to frame it. But then the other way to think about it is that in many ways, what I'm most interested in is how the community wants to manage a team that they think is not meeting their needs. Because in some ways, it's, again, from the external side of the world, like I tried to, in the program development side, I tried not to just go out and plant a team, right? The goal is to get everybody on board to help understand what this team is going to be doing, and so as those stakeholders learn about how the team is doing and what kind of barriers they're facing and what kind of steps they've taken to address those barriers, if the stakeholders are feeling like, we've given this team 18 months or 24 months or whatever the window is, and it just doesn't seem like they're able to serve the population well, or they're not getting the outcomes they thought they would get, then the question for us is, okay, then what do we as a ecology, I guess would include MST Services, what would we do about that? Do we want to bring in another provider? Do we think that the community just can't support the team? Maybe the problem has been consistent, low referrals for 3 years, and there just aren't enough kids. And one of the things we've learned from MST is that, well, two things. One is if you don't have enough referrals, your cost of treatment goes way up per youth. And then second is that you need to keep the therapist working the model for them to get good at the job. And so if they've only got 1 or 2 cases at a time, they really never get a chance to hone their skills and get really, really good at the parts of the model that they need to do well. So depending on that situation, I would turn the question back on the community and say, what do you guys want to do? You just want to not have an MST team? And we've had communities make that decision. There just doesn't seem to be a right way to do this here. We don't have the right infrastructure in place to support the team. Or we want to put out an RFP and do a new provider. This provider is welcome to apply, and they can participate, but we want to open up the frame and see what else, other providers would like to apply. And our job is to support the community in developing that process. Very rare that MST Services would independently go into a community. I think maybe once or twice in 17 years where we've actually gone in and said, we don't think things are going well, and we, MST, needs to, from a top-down, say we're going to shut this process down. It's much more communal than that most of the time. Anything else, Jen? Or
Not yet.
Okay. Then I'll do a couple more slides, and then we'll, it's about 12:46 or so, we'll wrap up and see if there's any final questions. So I've talked a couple different times about outcomes, and I talked at the beginning about the MST Institute and how we enter data into the Institute's, we call it the enhanced website, the data tracking process. And so I wanted to capture just a couple of screenshots here about ways in which the provider can look at its own performance, but also, depending on how the network is set up in the different communities, stakeholders can also either get access to that from the provider directly, or they can have access. There's just a small administrative fee for people to access the network directly. So in active conversations in North Carolina now with some of the different MCOs about trying to figure out if they would like to have an administrative access to the dashboard to be able to run clinical feedback information for the teams in their areas. So this is an example of a dashboard that you might come up. I've taken out the identifying information, but you might have 3 different providers and 4 different teams, and across a 6-month period, you can see, okay, Team 1 closed 11 cases. Their ultimate outcomes, living at home, in school, no new arrests, look pretty good. Team Provider 2's got some problem with some engagement. They closed, well, data always happens in context. They only had 7 cases. One of those cases closed due to lack of engagement, which pushed them in the red area, but it would only end up being 1 kid. They've got a problem with caseloads. We recommend caseloads should be somewhere between 4 and 6. Having 2 is, again, way below where they should be, which means they have a utilization issue. That may be a referral problem. It may be something else. We'd have to go and, again, look to the stakeholders in the community to help us understand what that means for that community. And again, Provider 3, they have 2 different teams operating. They're looking pretty positive. Strong caseloads, strong number of therapists on each team, little bit of a challenge in the yellow areas related to their adherence data collection. But for the most part, you know, they're a pretty positive team. They should be doing a good job for their community. So when you pull this dashboard up on the website, you get 2 pages. This is the first page, and then I cut it off. I did a screenshot. So this network was actually like 80 teams big. I just picked the top 3. But then you get the second page of the dashboard, and that's a summary of all of the use served. And what this does is take that, so if you go back up, the report period for this dashboard is the last 6 months of 2012. What the second page does is take that 6-month period and then rotate it back for 3 consecutive 6-month periods. So now you get a 2-year window of all the use served and the general functioning of this team across 2 years of this network. So again, this network served a little over 5,000 kids discharged, and about 4,700 of those kids had a full course of treatment. Again, no reds on the dashboard, which is really good, but some yellows in some places that would worry me. I'd want to see a little bit better in the adherence collection. No use completing treatment is just a little not where I'd want it to be. And again, across the system, I think I still have a kind of a utilization issue. I don't have an average of 4 cases per therapist. And I would be asking, if I were the head of this network, I'd be asking, okay, why don't I have enough kids in my system? Why are we not, serving the right number of kids? Again, part of that's about getting the right kids in the service and getting the families the evidence-based treatment, but it's also then about cost and sustainability for the providers. Again, you asked about earlier the Medicaid question. Medicaid teams in general, and generalities and averages are always hard, but you need to have 4.2, 4.3 cases per therapist to break even. And so if this was a Medicaid-funded system, 3.5 means in general people are going to lose money. That's a problem. And they can't do that long and can't keep the service in place.
Joe, we have a clarification real quick. Does FTE mean full-time experienced?
Full-time equivalent. Basically, it's a full-time therapist. 40 hours a week devoted to the job.
Great, thank you.
Sure. A couple of screenshots here. Those were specific. The two slides I just showed were specific to dashboards. If you wanted to get a sense of kind of how we're doing, the MST Institute on their homepage does keep a running, screenshot here at the bottom, the data report. And those data reports for the last 4 years are data reports for the entire MST system. So if you were to open one of those, I can't do it from this slide, but if you go to the web, if you go to MST, www.mstinstitute.org, and click to go, you'll come up with this page. Click on the data report, and you'll be able to see across 23,000 families, this is how we did. This is the number of kids that didn't get arrested, and these are the number of kids that is the average adherence scores, everything, the data like that. We try and make everything as public as we can, as transparent as we can. Again, the stakeholders should be able to look and say, okay, even if I go back to that last network and I pull up the network and I say, okay, so I've got these 10 teams in my MCO area, and I pull up the 2000 data report, and I can say, okay, my MCO area teams are better than the national averages. They're not doing quite as well as national averages. It sets the context for the questions around performance and improvement and getting better outcomes for families in ways that we think are healthy. I talked earlier about the network partner process and the idea of many times capacity and growth building are about local relationships, but we'd like that relationship conversation to be informed by data. Right? So yes, this, and we've had these situations happen. This is a local provider. They've been in our area for years, but their MST outcomes aren't good, and they've been not good for a while. And so do we need to say, let's move them to someone else? Or Do we need to help them do better? So, let me do another couple slides and then I'll stop. Another screenshot, this is www.mstservices.com. And there are a couple things here, again, to help you get information about MST that might be useful for you. If you go to the home page and you mouse over the Resources tab, that upper bar right next to the search bar, you'll get a drop-down menu, and there's a link for the MST library. If you click there, there's the instructions. On the right-hand side of that page, you'll see some information about MST. There's some fact sheets that talk about clinical outcomes, cost savings. There's some quick links that you can get information about blueprints and how MST fits in that conversation. If you click on that same home page on target populations, you can then, at the bottom of the screenshot, there's a handout for adaptations, and I'll just do a quick couple screenshots of that. Again, from a big picture standpoint, disseminating something that doesn't work doesn't help us. Doesn't help anybody. Doesn't help the families. Doesn't help providers. And so as we think about adaptations of MST, working with different kinds of populations, or what kind of things do you have to change about the model in order to help it work with that population, from us, that still needs to go through a research process. You just can't make an assumption that, oh, if I'm treating problem sexual behavior kids, I'm just going to adjust the model this way and we're going to roll it out and see what happens. We put that through our same kind of research process. We run a couple of RCTs. We want to know that it's effective in the communities. We're going to look for some purveyors and some provider organizations to help us with that. And so this is from left to right, how we kind of think through how we run those research questions. And then the bottom, so if you download this handout, this is the last page. The bottom of that page, you'll also then see the different adaptations that are currently being evaluated and where they are in the process. So the child abuse neglect population, that's mostly based on parent behavior. Those are kids 6 to 12 whose parents are abusing or neglecting them. The problem sexual behavior group, MST SA for substance use. Healthcare, juvenile diabetes, that's an interesting group of folks to me, that you can use an MST-based process to help kids who are not healthy from a weight standpoint or who don't take their diabetes. And there's even a small group out there who've been looking at youth who have been had some kind of an organ transplant and don't take their anti-rejection meds regularly. And when that happens, those kids go into some kind of a medical crisis, which ends up putting them in the hospital, and then again, lots of financial dollars attached to that, that if we can help the family manage that better, we can help them stay healthier and save money. So that's where we're after in this population, is how do we roll these things out, get them through the process, and get them ready for dissemination. So that's the end of my presentation. And Jen, I'll find one kind of last question or last set of questions from the group until we close up in 3 minutes.
Okay, sounds good. We don't have any at this time, but I could launch our polls, if that's all right.
Well, let me do one question. I have a question on my screen. I don't know how it got to me. It says, how does MST deal with cultural competency?
Okay.
So let me just do a quick minute on that, and then I'll give you the process back. There's two different ways that I tend to think about that. One is that I like the therapist to mirror the competency in the clinical or the cultural processes around the community. So, if they're in a community that has Latinos and African Americans, then I want the therapist to be Latinos and African Americans as much as possible. We all know, if you've been involved in hiring, that those folks can be hard to find from time to time. So the other way that I think about this is, what I try really hard to do is help the therapist be clinically competent. Because I know for sure that they will have a hard time being culturally competent with the family if they can't be clinically competent. I see lots of times when you can be of a different cultural background and you can join a family as long as you're clinically aware and you're astute enough to recognize that the cultural differences between you and them may need to be put on the table and talked about. So to the extent that you can do that and be clinically competent, you can become culturally aware and focused with the family, even if you don't have the same background. The way that I kind of think about that is that if the family process, if you shouldn't be able to make assumptions when you go in to see the family about any kind of cultural process, right? Just because the family's last name is Hernandez doesn't mean they have all the cultural processes or the stereotypical cultural processes of a Hispanic family. You need to have an open mind, go in, figure out what it is that they're like culturally, how that matches or doesn't match with MST, with you personally, with the supervisor, and then how we're going to address those things. So I think it's important to be clinically competent, and out of that will come cultural competence. So now, Jen, you want to launch your polls?
That sounds great. Thank you so much, Joe. That was great. We just have a series of 4 quick questions. If you could take a minute, I will give you about 30 seconds to answer each one. And I'm launching the first question now, so you can go ahead and answer that. Great, thank you. I'll launch the next one. Thank you. We have 2 more. Thank you. And our last question, take a minute to answer that one. We'll be finished. Thank you. And thank you again, Joe. If you liked what you heard today and you would like to share this information with your colleagues, you can visit the Advancing Evidence-Based Practice website in the next couple of weeks and find a recorded version of today's webinar there. Make sure to join us next month for our May webinar. We look forward to seeing you then, and have a great day.
Thank you, everyone.